John, hi, and thank you so much for joining me here on Faces of Digital Health to talk a little bit more about approaches that hospitals and governments can take when they're trying to invest in the digital transformation in healthcare. You're the Senior Director for Analytics for the EMEA region at HIMSS, and one of the main things that you do is basically work with hospitals on assessing their digital maturity. HIMSS has 6 maturity models, and I'm hoping that we can explain them a little bit more in this discussion. So let's start at the beginning. HIMSS as such is 60 years old. What's the history of maturity models? How did they begin? How do they get developed? Because you're also adding new ones.
Yeah, thank you very much, and it's great to join you here this afternoon. So HIMSS has a 60-year-old history. We were not always called HIMSS. We've had a couple of other names, but we've been using maturity models for 20 years, and in itself, that's quite an important point, because whenever you use a maturity model, it's always important that you have a model that has a history, which allows you to look back and understand how the model's developed, but also look back at others that have gone before. So you can always find a hospital who has a similar start point to yourself, using the same system, doing the same things, and that creates a reference point. And one of the great things about the HIMSS network is that these networks and reference points are established all over the world. So it's very easy for us to connect you up with somebody who's doing the same thing as you are doing. But the other most important thing is that maturity models have a future, because at some point you will need to remeasure, and you will need to remeasure using the same set of metrics that you used for the initial baseline assessment. And all too often, and certainly where I come from, these maturity models seem to come and go. A model's here today and it's gone tomorrow.
Mm-hmm.
And that's not very helpful when you are looking for the same process to measure continuous improvement. So the EMRAM, for example, has been reviewed every 3 years for the last 20 years or so. It was last reviewed in 2022, making it fit for purpose in 2024. So I think
If I just stop you, if I just stop you there for a bit,
yeah, sure.
Can we just go a step back and explain what a maturity model actually is? Is it like a questionnaire for hospitals? What kind of process is this?
Yeah, so we see maturity models all over the world, and I rather suspect that if you were to look at any country, you would see an example of a maturity model. And often it is a survey, it is a self-assessment survey that allows the care provider to complete a series of questions that, when analysed, will give you an indication of where you are against a digital maturity scale. So the maturity models that HIMSS has, they are all 1 to 7. And as you increase the number, you tend to increase the level of digital maturity.
Do hospitals ever get kind of downgraded? If, when the models are updated, how do you manage that?
Yeah, so that is possible. When we review and update a model, it inevitably becomes slightly more challenging. And as such, it is quite possible for a hospital that was previously at stage 6 to score at stage 5 against the new model. And I think, people are very accepting of that, because, they wouldn't want a model to be updated to actually make it easier. This is about raising the bar and about having models that are fit for purpose, and models that actually keep up with the rate of change in healthcare technology.
You previously mentioned EMRAM, which is the maturity model for EHRs. It's probably one of the models that is also most known among the public in the digital health space. I think 3,500 hospitals have been assessed so far. So can you talk a little bit more about that? You know, how are these hospitals chosen? Do they come to you? Do you go to them? Do you track how they're doing today?
So the EMRAM, the electronic medical record adoption model, is the flagship model. We've used it in the best part of 53 countries across the world. The number that you referred to, 3,500, is probably the number of assessments that we've done in Europe. Certainly, the worldwide assessment runs into the thousands, and every country is associated with a number of stage 6 hospitals. Those are hospitals where a member of the HIMSS team has actually carried out a physical on-site assessment. So the process of self-assessment runs between stages 1 to 5. Anybody triggering stage 6 will require a HIMSS assessor to be on site for a whole day, and that will mean that a very comprehensive assessment is carried out before the hospital can be promoted and declared validated against the stage 6 standards.
Is it quite clear how hospitals can progress from one stage to the other? Like, how do your recommendations or opinions look like? And to which extent, for example, do hospitals also compare each other? In some countries, especially in private systems, there's a lot more competition between hospitals for the patients. So I imagine that they might potentially be even more interested to position themselves as more developed, more advanced, more technologically driven. What are your experiences in that regard?
So the start point all over the world is very similar. A hospital will have access to the HIMSS survey platform and will complete a self-assessment survey. Once the survey has been returned, it goes through a quality assurance process, and we then present the hospital with a maturity model score, as well as a very detailed report which contains the gap assessment between where the hospital currently are and stage 7. On top of that, we also have a list of things that the hospital might need to do in order to close that gap. So it all becomes very logical that the recommendations within the report can be adopted into the digital strategy of the care provider, if of course they wish to adopt those standards. And that is a way then that the hospital starts to make progress against the model. The model is very logical, so it follows the way hospitals would typically increase their EMR level of maturity, but it could relate to infrastructure and analytics, digital imaging, depending on which model was being used. But the idea and the most important point is that at some point in the future, the hospital will measure again. And it's through that process that they can demonstrate to their sponsors, their stakeholders, that the money's been spent on the right thing, and the desired effect is then being measured.
Mhm. Given that you mentioned in other models as well, so there's DIAM for imaging, there's INFRAM for infrastructure, there's one model for community care and another one for community care. Can you explain a little bit how these models were developed? What do they entail, and who usually decides for them? So why do hospitals do several models? What's the mindset usually behind that?
So I think the development of anything new in the maturity model space comes as a result of market demand. So we listen very carefully to what the market is telling us, and if we believe there's a gap and a potential to close that gap, then we will go through a business planning process in order to develop a new model. So that's really how all the models started. In the development phase, we work with HIMSS experts, our key stakeholders in stage 6 and stage 7 hospitals. They are often senior technologists or senior clinicians, but we also work with the academic sector and, perhaps most importantly, our industry supplier colleagues, because we want to make sure that, to some extent, whilst we are vendor agnostic, we do need to align with the way the market is taking these various products. There will be little point us developing standards that were not applicable to the markets in which we operate.
So to which degree do you work with standards bodies for healthcare standards? Because I can imagine that it would be helpful to kind of create some sort of unification in the healthcare industry if the maturity models also include the recommendation of various standards. So, you advance in the digital maturity, which means that you're ready for larger interoperability projects such as EHDS, for example. So to which extent are these kind of projects interlinked?
So we are acutely aware that there are standards. There are standards for electronic messaging. There are standards for coding. There are multiple standards for security, confidentiality, resilience, etc. And where there's a definite international standard that is used by everybody, the model would make reference to that, because we are checking how compliant the organisation is against that international standard. What we try and avoid is referring to standards that are only relevant in one particular country, because the biggest challenge that we have is to find a way of making the models locally sensitive but globally applicable. And that is a challenge. So if we are aware of local standards, we will probably talk about compliance with local standards without actually naming them. And the HIMSS assessor would have normally done a bit of homework to understand what the local standards are in that particular country.
One of the big challenges in healthcare is that, in fact, every hospital has its own ways of doing things. Even if you have national guidelines, they adapt them to local needs. So it's very interesting to hear that basically you're also kind of adapting to local specifications a little bit. So can you talk a little bit more about that? So to a degree, when you see that a hospital is EMRAM stage 6 or 7, you kind of imagine the same level of digital maturity in the UK or in Taiwan. So where are the differences, and how do hospitals look at these differences? Do you ever get complaints around, the assessments or something?
That's a great question. And, over the last 10 years, I've been in hundreds and hundreds of hospitals. I'm not sure whether I've tipped 1,000 yet, but I've been in hundreds, and I've concluded that once you've been in one hospital, you've been in one hospital, and what that means is that whilst several hospitals will all be able to achieve the same standard, they often get to that place in a multitude of ways. And that's great because, we want the models to be flexible enough to account for different workflows, different customs, different practices, different workforce initiatives, and that's the vibrancy of Europe. And everybody's doing this in a slightly different way, at a slightly different speed, and that is to be encouraged. But if you imagine we need to overlay a set of standards that are consistent with what happens in Europe, Asia Pac, and North America, equally, that is very, very important. And the skill of the HIMSS assessor is not to understand the standard. The skill is to understand the context, because the context will change every single hospital that you walk into. And the challenge is to look at the context, look at that particular workflow, look at that outcome, and be sure that the spirit of the standard is being met. And only with experience do you have the knowledge to make that judgment call.
Who can become a HIMSS assessor? And the reason I'm asking that is because I know that you also do national assessment. It was done in Italy. It was done in Germany before Germany did their whole digital health strategy. So with those kinds of projects, you're in a position of assessing hundreds of hospitals at the same time. So what does that mean for the workforce that you have that's capable of doing those assessments?
It's very common for us to work with partners. We have a digital health transformation partnership scheme that runs globally, and that is a way of extending our workforce through a partnership scheme. And all the DHTPs have been trained to work with the models, to understand the standards, to allow them to work with hospitals in order to move from one stage to the next. And to some extent, they are going through a process of continuous assessment as they potentially start at stage 2 and take the client all the way through to stage 6, when the HIMSS assessor would come along and actually carry out the validation. When we do stage 7 assessments, we take people with us, and it's normally a team of 4, and we would have a chief information officer and a chief clinical information officer as part of the assessment team. And to some extent, they serve as external assessors, but they are very knowledgeable, they're very helpful. They don't make the decision for us, but they often help in collecting data to allow the correct decision to be made on the day. So to answer your question, really anybody can become a HIMSS assessor, providing, of course, you have the appropriate knowledge, experience and training, not only to understand standards, but to apply them in context.
I imagine that, this is kind of like a test day, an exam for hospitals, because you come in as an assessor, and at the end of the day, you say you get this badge or you don't get this badge. How often does it happen that a hospital, for example, would expect to get a stage 7, say, but they don't? And what happens then? Are you also under a lot of pressure that maybe your assessment isn't fair?
Yeah, once again, a good question. So if we get on site and we've been there for 2 days and we can't reach a positive decision, which would be a successful validation, then we actually see that as failing on the part of the client, but a failing on our part as well. Because we we have a process in place whereby we screen hospitals prior to the visit. We go through the questionnaire, we go through the report, and if we actually arrive on site and there are things missing, that is a potential failing in our processes. So whilst it occasionally does happen, it doesn't happen very often, fortunately. At the end of the day, we have 4 decisions. We can not validate a hospital, which, as I've previously mentioned, happens rarely. We can validate a hospital with recommendations, which is by far the most common outcome, because we can always find something that the hospital can improve. We rarely validate a hospital without validations, without recommendations, which is the 3rd outcome. The 4th outcome is we validate with a condition. And what that means is that we're absolutely satisfied with the result, but we've found maybe 1 or perhaps 2 things that just aren't right. That if there were many, then the outcome wouldn't be positive. But if it is a couple of things that we think the hospital can put right in order to really strengthen that validation, then we might give them 3 to 4 months in order to take corrective action. And the reason we do that is because the maturity models have this incredible link to patient safety. And we would rather the hospital put something right because we know that's going to improve patient safety than run the risk of not validating them and the hospital never taking corrective action.
What do you see as the biggest challenge, in digital maturity? Because we currently really focused on the hospitals as individual institutions, which to a degree is an easy part. In healthcare, we expect interoperability, we expect kind of a holistic care. So that's how I imagine that also the coordinated patient care model was developed. So that to me sounds much more difficult, because suddenly you have to work with several institutions and come to an agreement that they're going to connect, build integrated care plans, multiple care pathways, and protocols for chronic conditions. So can you talk a little bit more about that? And maybe what's an example of a region that would have the CCMM model achieved?
Yeah, you're absolutely spot on. Healthcare is not linear. We rarely travel in a straight line. We move between different care settings and different care providers that have been built upon geographical boundaries, political boundaries, managerial boundaries, policy boundaries. But typically, these boundaries are the way patients move through the system. And a good example, would be a process that took account of how patients move from primary care into secondary care, into community care, maybe a bit of home care before returning to the care of the family doctor or the GP. That would not be an untypical patient flow. And every time the patient moves between care settings, which we call transfers of care, the level of vulnerability increases, because we need information to follow the patient, clinical responsibility to follow the patient, and sometimes the ball gets dropped, and all those things occasionally don't happen. And the patient leaves hospital without medication, without a discharge letter, they get home without any follow-up physiotherapy. And those are all things that affect recovery. So being able to carry out a digital maturity assessment on the whole system rather than a single organisation is the main feature of CCMM. You asked about challenges. The biggest challenge that we have is to educate not just individuals, but organisations, regions, health ministries, that this is not about single organisations. But unfortunately, whilst we continue to fund single organisations, commission care from single organisations, and regulate single organisations, we will continue to conduct digital maturity assessments on single organisations. So if you were to change the commissioning, the regulatory, the financial regime, you would automatically switch the assessment regime from single organisations to entire economies of care, whole systems, if you will, or ecosystems, as we sometimes describe them. So that's the nirvana, being able to conduct an assessment on the entire system, because that's the most important thing. Hospitals are simply a secondary care provision. We spend most of our time receiving care in the community and the care from our own general practitioner.
Where do you see the biggest challenges in kind of easing the connectivity between institutions alongside all the changes that we see in healthcare, the move towards virtual wards, at-home care, drive to kind of daycare and day visits in the hospital, so patients spend more time at home. I imagine that to a degree this brings a new plethora of challenges when suddenly you potentially have new vendors that are trying to capture information in the home settings, but they use different standards that data structures or software in hospitals. So again, you're creating new frictions. What are kind of the recommendations there? And maybe there's a good use case that you saw in terms of how to bridge that. Is it policy? Is it mandating standards? Like what is the best way forward?
So first of all, we need a process of levelling up. When we look across a community, a region, or even an entire country, we still see examples of organisations that still operate on paper alongside organisations that are paperless. And whenever we have that scenario, the thing that I've just been talking about, the whole system working as one, just doesn't happen. And when we're looking for examples of interoperability, of health information exchange, that is only going to occur if the whole system is digital mature. And that makes us think about how the money is distributed, where the money is spent, and many communities, certainly in the United Kingdom and indeed elsewhere in Europe and in the Middle East, have recognised that we've got to move away from individual planning to whole system planning. The clusters in the Kingdom of Saudi Arabia are great examples of this. The integrated care boards in the United Kingdom are another example. And what these new mechanisms are trying to do is to switch from organisational thinking and organisational leadership towards whole system thinking. Because it's only when the whole system works well do we see all these great things around integrated care, home care, care out of hospital, hospital at home, actually working well. If there's no connectivity between our homes and the hospital, or the hospital and primary care, these things simply don't work.
what is the difference between the CCMM model, so the continuity of care model, and the community care outcomes model? Generally speaking, there's more and more emphasis in healthcare on patient-reported outcomes. Denmark, I think, already integrated patient-reported outcomes in their national patient portal. In the UK, One London is doing urgent care planning, and patients can already input basic feedback on urgent care plans through the NHS app. So we want that feedback information, and we want healthcare to move towards value-based care and focus on outcomes. So what does community care outcomes maturity model actually measure, and who usually uses it?
So C-COMM, which is the model you refer to, the community of care outcomes maturity model, will often focus on a single organisation. That single organisation may have responsibility for several care providers. Those care providers are non-acute, community-based, ambulatory providers. So they are not hospitals. They are community centres, community clinics that provide a full range of ambulatory services to people in an outpatient setting or in a daycare sense. CCMM, the continuity of care maturity model, looks at the whole system. And the whole system for most people would be primary care, secondary care, mental health care, community care, home care, social care, and perhaps the ambulance service or some other care provider that operates over a large geographical region. So those are the fundamental differences. C-COMM, single organisation, CCMM, whole system. And you're absolutely right. You know that there are some great examples. I was in a London hospital only a couple of weeks ago, and we saw some fantastic examples of hospital at home, and technology was monitoring and managing a number of clinical parameters, including vital signs, daily weight, spirometry, saturation, in order to keep that individual out of hospital. And we had a great conversation, looking at the benefit, the value. We see other examples of patients being able to report outcomes through extended care plans, through images and photographs that the patient might submit to a wound care specialist. So there's some fantastic ideas and some fantastic examples of innovation happening all over the place. Personally, I think the interesting conversation is about the economics, because to look after somebody in their own home means that there's been an investment. The spending is potentially much less than having somebody in hospital. That's a great thing. Is there a saving? Usually not, because the demand on hospitals is such that any spare capacity in the hospital is immediately consumed by the next patient in the queue.
Yeah, that's absolutely true. So yeah, healthcare is super busy. If I stay with the outcomes model for just another moment, can you share what are the criteria to have a stage 7 C-COMM validation? So what does organization need to provide to patients? Because I don't know, like if I think of patient outcomes, my immediate reference point or association is with the quality of care that an individual provides. So how does digital fit into that?
So I think with many of the models, C-COMM really isn't that much different. It is directed to to a different care setting. But many of our models have this golden thread that runs throughout them. So at a very basic level, to get a foundation in place, we would expect clinicians to be documenting electronically rather than documenting on paper, to benefit from clinical electronic alerts and warnings, some evidence of clinical decision support that might offer an order set or help with prescribing, ensuring that the prescriber gets the dose right or recognises a laboratory value or the weight of the patient or the allergy status, for example. So all those things are part of the foundation. With C-COMM particular, we're also looking for a high degree of interoperability. Ambulatory patients move a lot by definition, and we've got to make sure that community providers are capable of exchanging healthcare information with others in that local community. That might be primary care to secondary care, it could be patient to primary care, or primary care to patient, or primary care to primary care. So, the degree to which we see evidence of electronic messaging between patients and clinicians, or clinicians and clinicians, is often good evidence that there's been some investment, and that investment is starting to have the desired effect. As we move away from the foundations and go a little bit further up the building, we're looking at how the organisation is using analytics, how the organisation is using data, perhaps artificial intelligence, to not only look back at what's happened before and to provide an explanation, but to actually look to the future using prediction and prescription. And typically, predictive analytics will describe a future event. It could be a busy clinic or some kind of a seasonal event that happens in the summer or happens in the winter. But the critical part is the prescription, because the prescription helps the organisation with the plan. So not only do we forecast the event, but we actually give some ideas of what the organisation might do in order to manage that event in the future.
And how do hospitals basically decide that they want to undergo an assessment? So what's in it for them? Like, why would a hospital want to have an assessment on EMRAM or on their analytics or on their imaging status? So what's kind of the biggest benefits that they get out of that? I imagine that some leaders might see that as unnecessary and would perceive themselves as being very digitally mature. So what are your experiences in that regard in terms of the mindset or the feedback that you see on the market from various leaders?
People do these things for a whole variety of reasons. If you think about a typical improvement cycle, which is baseline assessment, plan, act, and remeasure, that is a typical cycle that a hospital or a primary care provider will be thinking about. Let me understand where I am today, what I need to do to move forward, actually move forward, and then remeasure. So many people will use any of the models for that simple reason, because they want to know where they are. Not just where they are when compared to their peers, but where they are in accordance with global standards. So that's the first thing. Other people are looking at a procurement process. They're looking to buy something. So the output from the maturity model can often give them an idea of what to put into the specification, because they want to be compliant with the EMRAM or INFRAM or DIAM standards at some point in the future.
Mm-hmm.
So to miss those standards from the specification that has been put together to buy a system may mean that they actually miss the opportunity to validate at some later date. Other people will use a maturity model to help them with a deployment plan because they want to deploy in a logical way. The maturity models are logical, and that allows them to layer their functionality in a very intelligent and scientific method. Some people just want the badge. Some people just want the trophy of the stage 6 or stage 7, and some people will do that multiple times. So we have a number of hospitals who are multiple stage 7 award holders across four or five different models, and once again that is done for great reasons. Occasionally,
But
there's some. Yeah,
that's
please go ahead.
yeah. I'm just thinking that, even if you just do it for the badge, it still shows that you're still quite digitally advanced, because if you get
Absolutely.
like an additional, basically confirmation that you're still doing great, that's still good. I think it's, yeah, I'm just thinking, because one thing that I wanted to really kind of tap your brains about is, when hospitals are buying new things, they really need to know well what they need, and that can be really difficult because technology is advancing so fast. And it's one of the biggest challenges in tender processes is how do you actually validate vendor claims in the responses that you get. So what are your experiences from working in the field in terms of what hospitals tell you that they wanted to achieve, but actually in the end couldn't, or were disappointed by technology? Where do you see kind of the biggest challenges, I guess, in the procurement, and the difference between the theoretical promise of technology and all the edge cases, and the challenges that show up hardly when you implement technology? I'm sure you have
Yeah,
many stories from hospitals.
yeah. So we work with industry and clinical systems suppliers and EMR vendors very closely, but we don't validate products. We validate hospitals and or validate healthcare providers. So we have many examples of where the same system has been deployed in two separate and different organizations, and the amount of variation and the outcome is very different. One goes well, one doesn't go well. And the functionality of the software is exactly the same. And when we look at the reason why one has gone less well, there are a number of core themes. First and foremost is all around culture and leadership. It's culture and leadership that constitute a success. And in third place, following very, very closely, is clinical engagement. If you don't have an engaged clinical workforce, this thing is going to be difficult. And I think the fourth thing is the ability to spend money on the right thing. But once again, many examples of where technology has been purchased tactically rather than strategically. And the hospital have simply bought the next shiny thing. And there's no context. It's almost a solution looking for a problem. And it's been deployed in complete isolation. So I always think, there's something about building the foundation, and the maturity model standards allow you to build the foundation. And stage 7 is by far the end point. It's probably the start point. Because what stage 7 tells you is that your foundation is sound and it's firm. And then it's upon that foundation that you can start and build and start to do some of the more interesting things. So you can become tactical once you have your foundation in place.
So does that mean that, for example, you start with EMRAM and get your EHR in order so you know that the data capture is sound, and then you can start thinking what you can do with that data and also look at what you can learn from the analytics model and build up on that?
Yeah, so that's pretty typical for hospitals to use more than one model. In some scenarios, INFRAM is used first to help people understand their capabilities of infrastructure and their ability to support it. And they do that because infrastructure is often a point of failure. It's like trying to drive a Lamborghini on a country lane. It doesn't work. So having a motorway network in place is often very important before you buy the Lamborghini. The Lamborghini being the electronic patient record system. So making sure that the servers, the wires, the cabinets, the network, the infrastructure, the points of access, the access devices, end user adoption, all those things have been taken care of before deploying electronic patient records is a very sensible move. So the two models we've covered in that scenario would be INFRAM and EMRAM, or INFRAM and C-COMM. When the electronic patient record environment becomes mature, it's often time to start and look at the information, the data, and the benefit of advanced analytics. Because that's why you've done it. You've done it to produce data in order to improve patient safety and increase the overall quality of clinical care. And so that's the point in which you might use AMAM to ensure that you are getting the best use out of the data that you spent so much money actually providing.
Yeah, 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 yeah. Uh, I wonder, is it possible that, for example, a hospital achieves high maturity on one model and say like IMRAM, but they actually don't, they are very low on the infram kind of scale? Is that even possible? Because I imagine that, for example, if you have something that's highly digitized, but then your infrastructure is not in order, and say you're a badge collector and really want the infram badge as well, then you would basically have to potentially throw the whole thing that you have for MRAM away in order to really advance in the infram stage. I'm wondering if that's even possible, because I'm going to put a very plastic example out there. So I recently visited a doctor who wanted to show me an IT program that he was using. And we couldn't see it because he couldn't open it because the computer was too old. There was some update that was required by JavaScript. And in the end, we just gave up. So that's why I don't know if it's actually even possible to be low on one level and be really high on another.
So within all the models, there's an element of overlap, and there's an element of connectivity between all the models. So when the models have similar demands, those demands are on the same stage across all the models. Let me turn your question into more of a positive. People will often ask, what stage of INFRAM do I need to be at to ensure that my electronic patient record program is going to go well? And the answer is not stage 7. So you don't need to have stage 7 infrastructure to have a stage 7 EMRAM in the operational sense. You just don't. So anything above stage 4 on INFRAM will ensure a successful electronic patient record deployment and would facilitate an organisation meeting the stage 6 or stage 7 standards on EMRAM. But you couldn't really score high on AMAM if you were scoring low on EMRAM, because you need electronic systems in order to carry out analysis. So there are some critical dependencies. So it doesn't always mean if you score high on one or score low on one, that's going to be replicated into other models. Hospitals that score well on EMRAM tend to score well on CCMM. But CCMM, don't forget, is about the entire community. It's not about individuals. So there are some key dependencies. It would be unusual if you were to score at stage 0 or stage 1 on one particular model and 7 on another. That would be unusual, and we'd want to understand that and look very carefully at what had made that happen.
We could probably create a lot of puzzles in terms of what goes well with another. But just to kind of wrap up this whole discussions, you basically at the beginning you said that when you see one hospital, you see one hospital. So I assume that every time you go to a new place, it's a bit of a surprise to see what you're going to see. And I wonder what surprised you most so far, or what kind of fascinated you most? Is there an institution, a culture, a country that you could pull out? Is there an anecdote that pops up in your head when the assessment was even specific? Because you work across cultures, you work across countries. Like, do you then usually take a translator with you? If you did an assessment somewhere that you don't understand the language in. So can you talk a bit about more of those aspects of the assessments that you do?
So I think over the last 10 years, it's been an absolute pleasure and a privilege to work across Europe and the Middle East and Africa. It's the most vibrant of all the regions in my view, and you see interesting things every single day. But maybe if I can sort of leave you with a few closing thoughts, and I'm not going to be drawn into naming single organisations, and I'll explain why not. But I will give you some food for thought. I think the first takeaway would be that every maturity model is flawed, but if you're going to use one, then use one that's got international applicability, has been around for a while, and has got a future because of all the things that I've previously talked about. We tend to be drawn towards the maturity models that are going to treat us kindly. And often you get the most benefit from the maturity model that initially appears a little bit challenging. Thirdly, we see good practice in places that we don't expect to see it. And not everybody is good at everything, but somebody is always good at something. And that's important because, you cannot go to a single healthcare provider and be wowed by everything that you see. You can be wowed by something, so for example, we can visit some of the Nordic countries and you see great examples of technology, but then you often see a doctor still documenting in a paper chart. So there are those extremes. And I think the maturity models they come and go. They will always measure different things, and it's right that they're challenges. I personally don't think it matters which maturity model you choose, as long as it's got a future, it's got a past, it's got international applicability. But the most important thing is you select one, because not using one isn't really acceptable. Not understanding where you are, where you want to get to, the process that you're going to use to make progress isn't really going to be acceptable. And you wouldn't want the chief executive in any country presiding over a hospital that was still using paper when everybody else had transferred to digital systems. So I think that's where I would leave the conversation. If you're going to look at somewhere that you perceive to be good, make sure that you know what you're going to look at, because some things will be great, some things will be less so, and that means that you should consider benchmarking visits rather than a single reference site, because as I just mentioned, everybody does something that is good.
I do want to ask you one more thing. So, because you mentioned paper, where do you see the role of paper in digital maturity? Because paper still plays a potentially very important role in business continuity. So what are your thoughts about that, about this whole hope that we're going to have paperless hospitals and paperless healthcare, where in fact, if you ask hospitals how prepared are they for a cybersecurity attack, they have to have posters on the wards, they have to have printers ready, they have to have a lot of paper ready as backup.
Yeah, and that's fine. And we're an organisation that recognises the use of paper. So if you still have paper systems, or you still have paper in the system, then tell us where it is. Don't let us find it, because we will find it. So trying to make out that you are paperless and then us finding paper, makes us suspicious. Hospitals will, because of cultural, legal, and policy reasons, will often be working with paper consent forms. So that is typical. People will often use paper to record a rapid response event, such as a cardiac arrest or a resuscitation. Doctors will occasionally annotate paper, so they might annotate a paper ECG printout. Someone might come into hospital with a paper referral or a sketch of something that has been provided by another healthcare professional. So paper's okay. The most important thing is we want to understand what you do with it. So the paper is an important part of the record, and as such, it needs to be absorbed into the record at some point. So we have several standards around scanning, and we want to see paper scanned into the electronic record as soon as possible. Whether the paper's a photograph, ECG printout, blood gas analyzer printout, it could be anything, but get it into the record. You can manually key it in and then destroy the paper. You can scan the paper, you can take a photograph of the paper, but whenever you are operating dual systems, one paper, one electronic, you have an element of risk. And the more you do it, we're talking to a hospital the other day that was 50% digital, 50% paper. That's an accident waiting to happen, because you don't know what you don't know.
Yeah.
Is it on paper? Is it in the clinical system? Where is it? So that work in progress of transferring from paper to digital has got to be as quick as possible, because the longer you run with dual systems, the longer that you have that risk of a clinician missing something.
Yeah. I think that's a great point, because sometimes things need to happen very fast in healthcare, and nothing is faster than writing something down on a piece of paper. Like one of the most interesting thoughts that I heard like in the big 8 years ago when I started doing the interviews was when a healthcare IT vendor said, "We're not competing with other healthcare IT vendors. We're competing with paper." Because yeah, it's much faster for a doctor to write something down on paper than to really document it and navigate the drop down menus, warnings, etc. So yeah, there's definitely a lot of opportunities still in terms of the digital transformation in healthcare and making it very easy to use and fast for clinicians.
Yeah, I mean, speed's not an excuse, and we shouldn't use it as an excuse, because when you've digitized something, you can make better use of it. More people can see it. It can be used for calculation. It can be used for analytics. It can be used to generate alerts, warnings. None of that can happen if you're operating on a paper system. But we recognise the role of paper, or anything that is manual. But at some point, you've got to get it into the system, and that's the most important thing.
Absolutely. John, thank you so much for today and for sharing all the
You're welcome.
insights. I'm sure we're gonna continue the discussion at some point because it's a pretty never-ending one when it comes to optimizing the healthcare system.
Yeah, thank you very much.